Hey, Sunil, how are you? I think you're muted.
Oh, sorry. I'm good. Good. How are you?
Good, thanks. I'm just gonna get you guys started. So I'm Jeff Weil. I'm the president-elect of the chapter, and we had some platform difficulties with Zoom. So I'm getting on to get you started, and then I will stop my video so people don't have to look at my ugly mug and stuff like that once you guys get started. And I see Rebecca's joining.
Hi.
Hey, Rebecca, how are you?
Good, thank you. I'm just here. I'll be a fly on the wall until we prepare. Let me just make sure I can share my screen.
Hopefully.
I joined a few minutes early just to make sure I can get.
Jeff. All right. Well, thank you everyone for joining us here today. We're excited to be able to introduce our topic for today. My name is Rebecca Clyde, and I am the VP of Education here in the HIMSS Arizona chapter. We are kicking off our webinar today with our esteemed panelist, Dr. Umar Iqbal from CommonSpirit, who will be heading up our topic today, utilizing technology to inform clinical best practice. On the line, we also have Sunil Kakade, Dr. Stephanie Lahr, and Dr. Joshua Reischer with us too. So thank you all for joining us. Before we get started into the webinar, I do have a little bit of housekeeping that I always like to cover, just to remind everybody what we have going on here. We wouldn't be able to do this without our sponsors, which are, of course, our incredible supporters here who make it possible for us to be able to hold all of our programming. So thank you, Pivot Point Consulting, CDW, NetApp, Nutanix, AP Professionals, Nuance, MathStech, and Sentinel One. We really appreciate your support and hope that you can renew for our following year programming. Just a quick rundown for those of you who are new to HIMSS. This is the Professional Association for Healthcare Information and Management Systems folks in the industry, and we have a very thriving Arizona chapter that we're very excited to be able to meet on a regular basis. We hold lots of events and functions. And then we are also having an upcoming survey that we'd like all of our members to be able to take if possible. So if you have a phone and you just want to grab this QR code here, we're always looking for feedback from our members in terms of being able to understand what else you might want to hear from us in terms of topics, events, get-togethers. We like to also socialize a lot here in the Arizona chapter. So if you're more interested in those, you can also mention what your interest levels are. And then just as a reminder, why we're here today is to really support the industry's vision to realize full health potential of every human everywhere. And those of us who are here and who participate in the chapter are all committed to the mission of reforming the global health ecosystem through the power of information and technology. A few upcoming events that are coming our way. We have on March 23rd, just a week out, our Spring Celebration Charity event. This is at Desert Botanical Gardens. It's an incredible event. I really recommend that everybody join if you haven't already signed up. We're offering discounts as well for provider folks, because I know some of you have been hit hard with some budget cuts. Then at HIMSS, we hope to see you all there in Chicago. We were just talking about the Chicago event coming up, and we will be hosting a cocktail hour sponsored by Juno Health on the 18th. And then we will also be having our next webinar on May 18th. Our topic will be hospital at home. So I think that's it for the housekeeping and administrative portion of the program. I'm going to turn it over now to our esteemed panelists who are here to cover our important topics. So Dr. Umar Iqbal, can you take over? I'll hand it over to you now.
Awesome. Thank you so much, Rebecca. So I'm going to give a brief intro of our panelists, and then I'm going to let you all sort of give a little background and sort of your journey. So I think we'll start with Joshua, Dr. Reischer. So he is the CEO of Healthnote and an entrepreneur with a passion for optimizing physician workflow, increasing patient satisfaction, and keeping people healthy through preventative care. We also have Dr. Stephanie Lahr on the line today. She is the president of Artsight, an innovative platform solution with the goal of bringing the joy back to medicine and reducing friction using automation and AI. So, boy, that's what we need. And Sunil Kakade, lastly but not least, is an accomplished technologist, senior leader with extensive experience driving data and advanced analytics, driven business transformation across multiple industries. He's passionate about creating value and implementing intelligent solutions in workflow, developed with AI and ML technology. So I appreciate you all for being here. Like Rebecca mentioned, Umar Iqbal, I'm the VP of membership for the Arizona chapter, and I also serve as an informatics technologist leader at CommonSpirit Dignity Health. So we appreciate you all for being here. So I think we're going to start with Dr. Reischer, and we're gonna hit all the panelists. So I'd like to just learn a little bit more about your journey, how you got here, any sort of background you can provide us, and then a little bit about your experience with technology and clinical sort of best standards and practice.
Yeah, that sounds great. Thanks so much for the introduction, and nice to meet everyone here today. So again, as was mentioned, my name is Josh. I'm the CEO and co-founder of a company called Healthnote. By way of background, I was a practicing internal medicine physician before starting this, but if I go all the way back, I originally studied political science and business, had nothing to do with medicine, had nothing to do with technology, ended up doing a post-bac afterwards, and got my first sort of feet wet in technology right after university, working for a small biotech startup. Always knew I wanted to do something slightly different, but wasn't quite sure what it was. And so ended up going to med school, wasn't sure exactly what I wanted to do, and went into internal medicine, which I think a lot of people who go into internal medicine are kind of love everything, but aren't 100% sure because there's lots of options, and that's what I did. And as I was going through residency, I just saw so many opportunities for improvement within the healthcare system that while many of my colleagues were focused on subspecialties like cardiology, pulmonology, you name it, I was like, hey, there's just so many problems here that could probably be solved by basic solutions that's what really got me interested. So all that happened in Tucson, Arizona. I was at the University of Arizona, got involved with the Small Business Association, and just tried to figure out while in residency, how do I make things better? So my first company was a in-home on-demand house call app that was inspired by working at the VA, because we would often get to people's homes who didn't need help, or get to people's homes who did need help and we were too late, et cetera. So that was sort of my first foray into that. After that, I worked for an organization called Iora Health, which some people might know in Phoenix and in Tucson. Fantastic organization, but again, saw opportunities for improvement. And while I was working mostly with geriatric patients, I realized a lot of these folks were already using technology. We were assuming they weren't. And I said, hey, couldn't there be a way that we can interact with them before they actually show up to the clinic? And that's what I focus on today. So while I was in residency and then working afterwards, I ended up starting this company called Healthnote about 5 years ago. And to put things into perspective, started with one other person, and now we see a little over 3 million patient visits a year. So a lot has happened. We can go into sort of what that journey was, but that's a little bit about myself, where we started and where we are today. So thank you.
Yeah, appreciate that. That's really an awesome journey. I'm glad to see you're a fellow Wildcat here for the U of A. So Dr. Lahr, we'll go with you to give us a little bit about your background and sort of your journey, how you got here today.
Yeah, absolutely. So happy to be here. I will jump on the internal medicine background bandwagon. Agree completely that it does seem to be one of those places where people end up who have lots of diverse interests. I actually started off my residency in OB in St. Louis and did a year of OBGYN, and then decided that still just wasn't quite the right fit, switched and went back to internal medicine. I trained in Galveston, Texas. And for those who aren't familiar, it's an island that tends to flood when there are hurricanes. I grew up in Montana, so I didn't have a lot of experience with that until I was in Texas. But in the kind of early 2000s, we went through an Epic implementation when I was a resident. And that was relatively early in that space for an organization that size. And, we went through the same old aches and pains as everyone does. But, when you're a resident, you just sort of know that that's what life is about. You go through aches and pains and learn and develop, and you just do it every day. We had a hurricane while I was a resident, about a year after our Epic go live. And 2 weeks after that, I had 5 feet of water in my house. The entire island was closed. We had no power. There was no running water. It was uninhabitable. But about 2 weeks after that hurricane, I was at a strip mall in Texas City, south of Houston, and they gave me a fax machine, a computer, and a phone. And I was immediately then seeing patients from that office, working with people who had been displaced. As you can imagine, if you have chronic medical conditions, and then you factor in the stress of something like a hurricane and everything that goes along with that, lots of things to work through. And it was a really powerful experience for me to see. Because I had trained on paper, and then we made this transition. And I just remember thinking about the millions of pounds of paper that was literally underwater in Galveston, and that we would not have been able to help any of those people. I could look up, you were in the hospital a month ago, I could see it. You needed a medication prescribed to North Texas, I could do it. So it was really an aha moment for me around, again, even just the power of the EMR, but technology probably more globally to really impact where we were going and what we needed to do. I then left Texas and went back to a higher ground and went to Coeur d'Alene, Idaho, where I was a hospitalist. And I remember meeting with the CEO in my interview, and I said, "Hey, what do you do for EMR?" And he was like, "Why? Because I'm guessing you don't want to use it. You don't like them." I'm like, no, I mean, I don't love them, but we need them, and just kind of want to understand what that looks like and want to help, because I figure if they're going to get better, I should be a part of that process. And that sort of organically started my journey as a physician informaticist. I went ahead and got board certified in clinical informatics. Again, it was just sort of one of those things. I helped my team, and then it was, well, will you talk to the cardiologist? Well, how about the intensivist? How about the ER? And over time, that sort of evolved. And then I left in 2016. I was recruited at now Monument Health, then Regional Health in Rapid City, South Dakota, to be the CMIO there and roll out Epic. We went live in 2017. And a couple of months after that, the CEO of the company said, "Hey, the CIO is retiring, my boss." And we really think having a physician being the tip of the spear when it comes to setting direction and strategy and helping our technology teams really integrate the tool sets that we need could be valuable. Would you be willing to be the CIO? And I said, sure, let's do that too. Yeah. So I took on the CIO role and was in the combined role of CIO and CMIO starting in January of 2018 until this past November. And now I am the president of Artsight, and we'll talk more about kind of what that is in a minute. But this is my first job ever outside since the day I started medical school, right? I've always been on the provider side in one way, shape, or form. So entering over into the vendor space, I met the founder of our company in June of 2021 with my chief nursing officer. Artsight is a sensor network platform that is basically designed to augment clinicians at the bedside and reduce that friction and take some of those tasks away and allow them to do more. And I was really, really excited about how they were layering that technology into the workspace. We began a deployment at Monument Health, and we kept in touch. And basically he said, "Gosh, would you be willing to take your excitement and bring it to the company?" So I joined as the president of the company in November of this past year, and have had a wonderful ride in this first few months, getting to know kind of what that takes. I say that I asked for the president role because I wanted to be able to, maybe kind of like the internist in me, stick my hand in a little bit of everything and be able to participate. And so it's fun to hear and see the different journey of physicians and the physician roles that have evolved in the technology space. And so happy to be here along with the rest of this group.
Awesome. Absolutely. Yeah. It's always cool to hear everybody's journey. We're going to take a little bit of a different twist now. We have Sunil. So Sunil, maybe a little bit about your background. I know you come from more of non-healthcare and then got into healthcare because you saw the need. And so you look at things a little bit differently than maybe some clinicians do. So we'd love to hear your journey and how you got here.
Great. Like my CMIO, he already started, giving me recognition as I'm his physician assistant. So I learned a lot of things working with him. I'm by education and practice. I'm an engineer. I'm a mechanical engineer. In 1992, I was doing my master's and working on the problem that is continued with my journey. And the problem that I was working on was when machines manufacturing some part, the tool that does the manufacturing, if it breaks in between, it causes a lot of damage and you have to restart. So they wanted to predict that, like, can you stop machine before that breaks? So that means you want to start prediction. And I was just working on variety of algorithms to do that. And I finally found an algorithm that is fault tolerant and can work with less amount of signals, or signals can go back and up and down, and that's a neural network. So you all probably hearing the chat GPT and deep learning and neural network. I have to code that in C++, and I will never forget neural network and that AI journey where you can use AI to start predicting the things. Story fast forward, my job was in the programming, and then I joined a retail organization, and guess what I was doing? Trying to predict what will be my sales, what the customer will buy, and it's trying to find out what good customer will buy in a combination. It's all about taking data, finding the patterns, finding the similarity, finding the anomalies, and doing a prediction. And from the retail, 10 years back, my boss happened to be from Phoenix area. He came in here and he joined with Dignity Health. And he said, we have done a lot of things. Do you want to put all of our energy, knowledge on, purposeful work that is like saving lives? And I came in here and started adopting some of the algorithms that we matured in retail world and tailored for healthcare workflows, and then we put into the workflow. So that's my journey. What I've learned here is the terms like big data and deep learning and AI. Those will come and go. The core of I think all we do, especially in the healthcare, is capture the data and find these enormous combinations that can happen with every individual, different medications, different conditions, and find that needle in a haystack that could save somebody's life. It's a challenging thing. I think being from mechanical engineering to supply chain to retail to healthcare, one thing I would say is healthcare is the most complex. It's not a big data, it's a complex data that creates a lot of challenges to do AI. That creates a lot of challenges to do an analytics. Anyway, I'll stop there, but that's my journey.
No, that was perfect. Actually, I'm going to use that to sort of segue into our first sort of question that I have for the group. And then, I'll pick on choose one of our panelists to start and give us. So based off of sort of what Sunil said, right? Wealth of data out there. How do we start figuring out where that pattern is? And there are some challenges there. can we talk about maybe what have you seen as being one sort of success story in your personal? I'm sure you guys work on a number of different initiatives, whether it be where you're at currently or maybe where you were at previously, but is there one sort of success story that pops out in your mind that used, it could be data or any sort of technology, and that could be rolled out into clinical practice? So we'll start with you, Dr. Lahr.
Perfect. Okay. So I'm going to use something that's a combination of my time at Monument Health, but while we were using the Artsight platform, and I think maybe does dive in, also dovetails a little bit into that conversation around the use cases of artificial intelligence and automation, as well as how to advance clinical. So along with the problem of us, what do we do with all this data and how do we make some sense of it? The reality is one of the challenges we have in medicine is we don't often have high fidelity data. Most of our data is captured by our clinicians, which inherently means it is flawed, right? It doesn't, like when I say the patient came into the operating room and documented in the EMR, that's not real time. It's not truly reflective of what really happened. It's reflective of the time that I believe it happened, had the time to document it, right? So a lot of our data, and we want this really high fidelity data, and we're going to need it to find those needles in a haystack. But one of the challenges is, while we want to do all this process improvement, we either, if we've had the volume of data, it may or may not be as accurate or high fidelity as we need. And sometimes it's just hard to get the right high volumes of data. So at Monument, when we were rolling out Artsight, so in Artsight, we use, again, a variety of sensors. One of those major sensors that we use is computer vision. And while a big part of the project was leveraging it in the patient room to help nursing, we wanted to leverage it for Leapfrog for hand hygiene monitoring. And because you need, 200 visualizations a month per unit. If you've got a 7-floor hospital with 20 units, that's now a lot of manual observations to do. So we said, well, let's use this platform that we already own. Let's put up some cameras. We don't even have to put one up at every room. Let's just put 50 up throughout the hospital, and let's capture that data so we can, get that information that we need to submit for Leapfrog. Because as you guys know, probably, like, Leapfrog doesn't actually even care how good you're doing at it. They just want to hear that you're measuring it and working towards something. So we put the cameras up, and suddenly went from, barely having enough to 40,000 observations a month. And now it was like, well, what do we even do with that information? What does it mean? And the original data was 40-ish%, was the compliance with hand hygiene events. And of course, everyone was like, well, that can't be. That definitely cannot be. Our physicians and nurses are not, that's not representative. So we started digging in a little bit. Well, 40,000 observations represented all kinds of people going in and out of the rooms. And so then we went to Artsight and said, well, we'd like to differentiate patients from caregivers from non-caregivers. And so we're working on the algorithm now to differentiate who is a staff from a non-staff, and not like by a badge, like an RFID chip, but literally, what do they look like? What are the things that represent a person that would work at the hospital? But one of the things that I thought was really amazing, and the infection control team, I really commended them for how they were thinking about it, was they said, okay, so we want to understand and segregate the data and understand it a little bit better, but maybe we have a problem we didn't even know we had. We've got family members, visitors going in and out of rooms. They don't participate in hand hygiene at all. There's nothing to say that a 9-year-old who runs into the hospital room and jumps up on their dad's bed after surgery can't give that person an infection. Maybe we need to think about what we're going to do and how we're going to, again, it's not a technology, it's an education. It's a work with patients and families around the importance of their own hand hygiene while they're coming in and out of the rooms. And so to me, like, this wasn't even the problem we were trying to solve. It was a problem we actually didn't even know we had. And I think where we are right now with technology is we have a real opportunity to leverage technology to be the sort of process improvement engineer that we want to have in every room 24 hours a day, but can't, because we can't afford or, have the people to do that work, but we need the data and certain kinds of it and certain amounts of it in order to really understand. So that is, again, I think a fun example that blends the two things together and highlights where we're going to be going with data and how we can use it. But sometimes it's helping us identify things we didn't even know were wrong.
No, that's really cool. Yeah, that, I was thinking about 10 plus years ago when we used to have folks in the hallways of the hospital, infection control people with like a little clipboard and secretly sort of monitoring. So we certainly have come a long way, and now what we're going to do with that data will be interesting. And now you're seeing even other insights that you may have not even recognized were part of that problem. So that's a great story. Maybe I'll go to Sunil next. One sort of success story that stands out to you that you've either experienced or witnessed or have helped worked on?
Yeah, and again, I'll go to AI theme here. When I moved from retail, some of the learnings that we had there was like you have to respond for the information or insight that you have very swiftly. And the use case that I fortunate to get was like early detection of sepsis. Now there is a rule-based engines around that, like you can detect it, but can you increase the wider net and start finding the sooner as possible? And I think that was one of the use case. I feel very proud of, like we advance our knowledge than what's the commonly available information is. So we went from more deterministic way to through the NLP language, some probabilistic way to see, okay, potentially this is started sooner, and giving that insights into the workflow to the care providers. And I think that has made significant difference. We have some publication on that, like is available. But what that taught me, which is in the life cycle since the patient arrives to patient discharge, we have several touch points where we could introduce augmented intelligence to our providers. And the situation where shifts are happening, providers are not like constantly available. One nurse could go, second nurse could come. Having that continuity of consisting alert, behaving and responding to unmanned way without human intervention is something very powerful. I think it is a peace of mind that you can have with all the distraction and potentially people going. There is some eyes and systems monitoring. So to me, like putting some use case like that, which is running 24/7 for every admitted patient, was very powerful story.
Absolutely.
And the extension of that would be, now that you have that framework, right, you could extend that to COTI or HAPI or other type of infections, and you could make the ICUs less stressful.
Mm-hmm. Absolutely. Yeah, no, that's an important one. I know, obviously sepsis is the number one, killer in hospitals across the country. So anything we do to improve outcomes, mortality, it could be, length of stay, a number of different things, readmissions, there's post-sepsis syndrome, there's a number of different things happening across that. So that's actually a very important use case, and there's a lot of work being done on that, both here locally, nationally. Dr. Reischer, I'm gonna pick on you now. Sort of a similar question, one sort of use case or something you've seen around technology that you've been working on or maybe have experienced previously.
Yeah, absolutely. So maybe I'll start with just a little bit of background and then focus on what the use case and the case study that, or a couple of case studies that we've done, at least on our team and with our company at Healthnote. So again, overall, we focus on the problem of clinics having many repetitive tasks and workflows that they do every single day, and multiple different people on a clinic team, right? So that's everything from checking patients in to gathering basic pieces of information. So let's call it the intake process. I'll call it the history gathering, all the pre-visit items that we often do during the visit or at the time of visit. And so given the staff shortages, turnover, challenges with sometimes accessing existing technology, that's kind of the focus that we have. And so the way our platform works is that we send a link to patients via SMS. Patients tap on a link and then they answer a series of questions that we ask them. And through a variety of mechanisms, we get them to answer somewhere between 75 and 90% of the time. And I think, Dr. Lahr, you hit upon something earlier about talking about technology and operations. And really what I've seen is when you marry the two really well, that's where we get some of our clinics to get 95% completion rates. And it is not just technology, it's actually marrying the two together. So technology is super helpful, but if you don't understand what's going on, just like what you said in terms of hand washing, right? That's great that we can figure it out, but then what do we do about it, right? And then identifying that problem and then figuring out, oh, actually, we found some new problems and how do we solve those problems together, right? And so we had it from a pretty similar angle there, or a different angle, but similar thinking. So for us, the way I was thinking about the problem was, hey, before a patient comes in, someone comes in with, let's say, a fever, rash, and aches in their body. And physicians are thinking, okay, is it cancer? Is it an infection? Is it an autoimmune disease? You're trying to figure out what a patient's coming in with when they come in with a list of symptoms. And we have limited time, limited resources, and sometimes don't ask every single question under the sun. And if a patient comes in and, I forgot to ask about recent travel, and there's something in their history that I didn't ask about, it's very easy to miss a diagnosis, right? And to figure out what that is. And so the use case that I often bring up is just kind of a clinical vignette that everyone knows about in medicine, like, oh, someone went hiking in Connecticut, maybe it's Lyme disease, right? And so it's simple, and it's also something that gets missed all the time because not every patient has the classic rash that looks like a target for a doctor to figure out. And then Lyme's disease goes undiagnosed for many, many people. And so sometimes it's simple history gathering on a consistent basis with all patients who complain of a rash, that if the provider had in front of them, they can find something that may have otherwise been missed. So measuring that is extremely difficult to do from a clinical standpoint, right? How do you measure the impact of, oh, now we gather better information and then measure clinical outcomes? You'd have to essentially do clinical studies like pharmaceutical companies do, which is extraordinarily expensive. So from our point of view, what we do is we measure the rate of patients answering questions, but then we also measure what is the documentation burden and need for providers, both before and afterwards? So something that's known as post-visit documentation rate. So the amount of time that a provider spends on documentation after a patient visit has concluded. And so what we've seen is over about 6 months, we see 30+% of the documentation that's usually done after the visit goes down. So about 30% less after visit. And during the visit, what we found is 47% decrease in keystrokes. And that's not just for physicians, that's actually across all providers in the office, everyone from the front desk, medical assistants, nurses, PAs, physicians, et cetera. And for me, the whole goal of us starting our company was, how do we enable more time with the patients and help with education, advising, et cetera? Because having a patient spend their time regurgitate what they know to 3 different people is really not the best use of time for the patient or the rest of the care team. So the case studies are really around what is easily measurable. In the future, it would be great to measure some of the outcomes there, but that ends up being really, really difficult to do just from a data gathering standpoint.
Yeah, no, that's a great use case. I know, obviously documentation burden, all that, that's a big ticket item right now around just burnout for our clinicians. And then same with patients that experience, 3 times you are answering the same questions. So whatever we can get in advance of their appointments, that's really where technology is sort of headed, and we're moving in that direction. I'm gonna get into a little bit about, you've touched on it, so I want to talk about a little bit about the operationalizing this technology into our workflows, right? So we do it all the time. We look at a problem, and then we come up with a solution. We can look at technology, but then how do you work that into sort of that people process portion of it, which I think we always talk about being one of the most important elements of that. So maybe we'll start with Dr. Lahr. How have you seen sort of technology being implemented effectively into workflow? There's a lot that goes in it. Usually there could be resistance from folks. It's a big change management thing. It could be a cultural thing. It's a number of different factors that play into sometimes us getting our technology rolled out into healthcare.
Yeah.
Sometimes folks are just very used to doing what they're doing. They're like, nope, this works for me. I don't want to hear it. I don't want to talk about it. So what have you seen being effective? How do you sort of integrate technology into workflows? Some pointers on that, or what you've seen being effective?
Yeah, it's a great question, because the reality is, and this thread keeps coming through. The technology can be awesome, or it could be terrible. Either way, if the people aren't a part of, making it happen, it will look like a terrible technology, no matter what it's capable of. And so I think really, really strong for me has always been, in fact, in my CIO, CMIO days, I felt like people would actually almost come to me now ready with the answer to this question, because I would always say, what's the problem we're trying to solve? And I actually was looking at in the chat on the questions, providing a pathway to going from massive amounts of data for machine learning to proof of concept to clinical setting. I think what we really have to do is flip that equation, right? We need to start in the clinical setting. We need to identify what is the problem we want to solve. Then we got to go out and look for the right partner implementation tool in order to solve that problem. We're in a really interesting place right now in healthcare, in that there's a solution for every problem out there. Mm-hmm. Some organizations don't have those problems, or don't have them to a degree that it's worthy of making the investment in solving that problem today. And I think if you start with something in the clinical setting and sort of say, what do you need? What are the problems? And then you look at the arsenal of what you already have, or what's out in the marketplace, and deliver that back and partner together and say, would this be a solution to your problem? Is this a partial solution to your problem? There's the need, I think, to start with the problem, and then to string the participation of whoever that end user is. They don't have to be just clinical problems. If you want to solve something in revenue cycle, well, for the love, go talk to the revenue cycle team and ask them what their problems are. Don't go to, your favorite trade show and pick out your 7 best, interactions and then come back to the organization. Those are the ones that fail, unless that is tied to, you have a problem. I love going to a trade show, but mostly it's documenting, like, this is what this team does and what they'd offer. And this is what, even like some of the speed dating opportunities that are out there now with vendors. I love doing those too. Not because I'm ready to go back and put them all in. It helps me as a leader create the arsenal of what's available and the understanding of what's available, so that when I'm working with operations and they're telling me about a problem, I'm super informed about what we either may already have available or what's out there that could solve the problem. And I think if you start there, you're setting yourself up for success from implementation, because they're engaged from the beginning. They're excited about the fact that you've asked them what helps them and what makes things better for them. And then if you deliver on that, you're a win. So coming back to the question that's in the chat, I mean, starting with massive amounts of data and crunching it, and then finding something's wrong, and then going to the clinical setting and saying, here you go, here's a tool to solve this problem that we think that we found by crunching a bunch of your data, probably not the most successful. But if you can put something in that helps them today, and then tomorrow come back to them with the data you found and say, here's something incrementally we could do to make things better. Is this a problem for you? Right? You build that trust and that layering interaction of adoption.
That's interesting. That's awesome, actually. I love that. Flipping it around, looking at it, you know, the other way. So I think that's very important as we look at, you know, projects that we're doing or how we help folks get buy-in. I mean, yeah. So it's not really the fanciest dinner you're getting from the vendor, is what I'm hearing here. Sunil, what are your thoughts on, you know, I know you work closely with a lot of leaders throughout the organization, operations, getting tools and technology rolled out into workflow. What have you seen that works?
Yeah, I'm going to compare healthcare with other industries. The last mile in other industries is the easiest mile. The most difficult mile in healthcare is the last mile. So we, like I said, I mean, if we will spend, and I'm just comparing and contrasting, I will build a 400 model in retail to, you know, predict what color, you know, particular shirts will be sold in what location, and I'll get that to the highest level of accuracy. And I'm not worried that I can deploy that within a week so that people in the store knows exactly what to do, or on the website. In healthcare, unfortunately, that friction at last mile is very high because it's controlled by EMR. EMR doesn't want to add any additional functionality than they want to add. If there is no, you know, interoperability. Now we have technically, Smart on Fire is a technology that has enabled, it's happening, but is it happening with the open heart from the EMR companies? No. And I put so many Smart on Fire application. I put actually one of the earliest one with one prime EMR company, and they don't have any investment on their side to make this work because there is no additional revenue coming for that. In fact, like it's a cannibalization for their functionality. So guess what? Like we as a in a healthcare, and the HIMSS is a great place to start advocating is, are we going to tie our future with EMRs, or are we going to be willing to give some way where we have a new device coming in where you have all the AI apps are dropped and it's you know, just like your phone, you are free. Now I know there are a lot of that mindset change is going to take time, but I think the explosion of AI and AI related applications that are coming, and the apps that like Joshua is building to improve the patient and provider experience is going to exceed the value proposition that EMRs bring. And now at that point, I think some provider organizations or some providers are going to start moving away from and may use EMR just for the regulatory documentation purpose. To me, that is what like the getting into the workflow needs to be of, you know, frictionless, and that is not there today. It's made, every effort has been made to add one more layer. Now that's technology side. On the other hand, like, you know, the governance side, right? You have months and months of change management time to put one app into the EMR. And so long way to go in getting into workflow. I'm concerned and worried that, like, you know, this wave of these AI applications that is evolving should not frustrate the startup community, should not frustrate the investor, and they will pass on healthcare and they move on and saying, you stay 20 years back where you are in terms of technology.
Yeah, absolutely. I mean, what you're saying essentially is, it's that last mile is the hardest mile, I think, because right now everybody is sort of at the top and we're asking, and say we have a new fancy tool out. Now we're, hey, like, guess what? Your plate is 100% full. Now we're asking for 120%. So really these tools have to be integrated to shave off, something to get something. So I think that's where a lot of work really is being done. So Dr. Reischer, what are your thoughts on, I mean, you're in this space. So, when you go to an organization, what's sort of working for you in regards to smoothly getting it into their workflow, getting adoption and buy-in?
Yeah, so just as an example, I just came back from Little Rock, Arkansas about a week ago, and I went to go visit 3 of the groups we work with. So we work with 3 large specialty specific clinics. They each have about 60 physicians in each of the groups, with somewhere between 8 and 15 locations around the state. And it was interesting to see how differently they were using our platform and software. And I'll give, from a results perspective, some were okay, some were good, and one of them is our best performer throughout 300 plus locations that we work with. One of them was the best. And the software is the same everywhere. There's really no difference. And then diving into, why is this so different? And actually the way it was being used was so different. And some of it, I'd say, is things that we could do better. And some of it is operationally, what was the alignment when we first started? What are the operations like when we got there? And then what is it moving forward? Groups that maybe have high turnover, right? It's really hard to keep a consistent workflow, and you have technology, but there's different people all the time. Things fall through the cracks, right? So from what I've seen is institutional alignment from the top is extraordinarily important, that whatever technology it is, it's not just buying a technology and paying for it. It's actually using it, implementing it, understanding, hey, what value are you getting from it? I think the organization, the clinics, health systems should expect to figure out, how often should I find out what value I'm getting from you, the vendor, right? Like, are we talking once a month, once a quarter, once a year? And how do I know that and prove that? And vice versa, show me another organization. Actually, so while I was there, 2 of the organizations had a meeting on one of the days, and they couldn't believe how different they were using it. And the one who wasn't performing as well was like, wow, we learned so much, not from us as a technology vendor, but actually from their peers and how they can do things better. So I think it's really important to build some sort of a network so people can see how each other use it, because if you're not speaking the same language, it's really hard to get that same sort of a level of success. So I think there's institutional alignment, but then there's also collaboration between institutions, because then everybody really wins. So that's the experience that I've seen.
That's great. Yeah, no, I totally agree with that piece. You touched on this a little bit, and it's actually the sort of the next question I wanted to ask you all. When it comes to sort of measuring outcomes, showing value, so now, right, technology, we've implemented it, great. How have you seen, whether it's through your companies or, the organization you're at, how do you show end users, clinicians, administrators, our finance folks, whoever it is, how do you show value? And value could be in a number of ways. It could be efficiency, time, it could be experience, patient, clinician experience. Any sort of, do you have maybe an example of where you've really shown value and that folks are like, okay, this tool is really working, let's continue, let's move it forward, however. So maybe Dr. Lahr, we'll start with you around some of the ROI type stuff around these tools.
Yeah, ROI is a really interesting driver for us in healthcare. I think we are generally pretty entrenched in a very traditional monetary ROI sort of paradigm. And again, it's because most of us, our margins are, on the provider side are thin. And so if you can't show a financial ROI, right, there you hear no money, no mission, you hear, all of those things, like you can be an amazing not-for-profit organization, but you still have to make enough money to keep the business going and to be able to provide the care that you want. And because the dollars and cents are so tight, we often look to ROI in a really, again, pretty structured way of what are the dollars I'm going to get back. I think this is where, from a technology perspective, as technology leaders, we can look at the power of a platform and platform play in order to help address that. When you think about EMR as an example, we use EMRs for a whole bunch of things because we've already made the investment. And with that investment already there, the more things you can use it for, the more you get out of that investment. The tricky part is that it's probably, EMR is probably not going to solve physician burnout. It's probably not going to solve nursing shortages. It's not going to solve, right? That's not really what it was designed for. But if you can look, and the other hard part about those problems is, how do you put an ROI on physician burnout or nursing shortages or nursing turnover? I mean, you can sort of say, well, tangentially speaking, we've noticed that when we have high nursing turnover, our teams are lower performing. We see fall rates go up. We see patient satisfaction go down. But again, to some of the points that we've been talking about, that's a bit nebulous and hard to prove. You're definitely not going to show causation. It's going to be correlation at best. And yet that ends up meaning a lot of those problems go untackled, not only unsolved, but untackled, because we're so tied to this financially driven ROI. I will save the dollars here to pay for the system here, that we never get to the point of solving the really gritty problems, the last mile problems, the workflow problems, because it's much more difficult to solve that. So I guess what I would say as we think about ROI is, one, there's never been more of a reason to think beyond traditional ROI, have these conversations with your CFOs and other leaders in the organization to say, you hear business leaders all the time say, we got to spend money to make money. It's a little bit of a play on that, but a little bit different. If we don't have the nurses, we're not going to fabricate them out of nowhere. We've got to come at this in a different way. We have to tackle that problem. So we're going to have to be willing to measure things that are a bit more soft. Those are going to, you can measure nursing satisfaction. Great. That's something you can put on a chart. You can measure patient satisfaction. You can put that on a chart. You can look at nursing retention and put that on a chart. You can look even at things like nursing hours of overtime. That's actually a financially driven thing. But when you walk around a unit and you see people smiling and you see a high performing team, like, the nurses don't need to fill that out. If you're doing this kind of ROI work, you're not doing it for the people that are the end users. They know a good tool when they see it. They know if it's solving their problems. But in order to get the buy-in of everyone else that you're going to continue the rollout, you're going to have to measure something. But I think we're going to really have to start changing how we think about ROI and looking at some of the softer things, because the really big problems that are in front of us are not going to have an immediate cash return on advance.
Absolutely. Yeah. I mean, I think you said it best. It's more of a correlation. It's multifactorial. Obviously, burnout, you can't just blame, oh yeah, the vendor, the EMR sucks. That's why our clinicians are burnt out. No. Far beyond that. I'm going to, just in the interest of time, we have a couple of questions, or one question from the audience, and then I want to push things a little bit ahead. So you guys are already sort of in this groundbreaking, pushing technology, which I love to see and hear. You all are doing great things. Where do you see, and maybe I'll open it up to either Sunil or Josh, where in 5 years down the line, it could be longer than that, where do you see technology and healthcare sort of headed? even farther than where you're currently at, whether, what tools are coming out. I hear a lot of things, around augmented sort of reality and that type of thing. Is that on our roadmap, or what do you guys envision where things are headed in technology? So maybe Dr. Reischer, I'll open it up to you.
Sure. So one, I think there's so many ways, of course, we can go here, but I'll give just one example related to what we do, but talking to a physician who I was asking, a user of our platform at a large academic medical center, and I was asking him, hey, what are we doing today for you, or what are we not doing, I'm sorry, that you want or expect us to do, and that not just to have us as a nice to have, but like what would we have to do to make you afraid not to use the technology? And essentially what he answered was, today you gather information, you collect it, you put it there, it saves me time. The patient feels like I know them, that's awesome. But the truth is, I know a lot of this information, I know how to ask these questions, I can do all of this, right? And so 95% of the time I can do this, it saves me time, and that's great. But what would make me afraid to not be using something like this is that if you were able to show me that, I would have missed X, Y, or Z, and even if it was 1 or 2 patients a month, right? Where if I didn't ask something, or if I didn't recognize something, but you found it, that would make me afraid to not use technology like this. So as an example, there are technologies today that look at imaging, right? You could look at an X-ray. You've trained the system to look at 10 million X-rays, and it can help find a lung mass or some abnormality in an image. Computers are better than humans at that. They're maybe better together, right? So maybe the human is like 97%, the computer is maybe 95%, you put it together and it's 98 or 99%. So I think about the same way, how do we not just use imaging, how do we take all the information about a patient, put that together, and enable the physician to get to the 99% versus the 95%? That's the piece that I focus on and think about on a daily basis. I think from a future perspective, there's so many different directions we can go, but that's kind of the place that I think about as you have a short period of time between a patient and a physician or other provider when they're together. How do you make sure that time is really optimized and enable everyone feeling like, hey, I'm going to get the highest quality care, and technology helped you get there, right? Just as an example, I think a lot of people probably feel like maybe the Mayo Clinics of the world, you get better care because you're spending time with so many different providers, and you could argue, hey, well, we pay more money for that, and you have all these people, and not everyone has the resources to do that. Well, how do we use technology to democratize that, where you know that you're getting the same quality of care everywhere, and you might be getting the same quality care everywhere, but how do you prove it, right? So everyone feels that way, and the experience is kind of standardized to a degree, because I think right now many patients feel that the way they go to the doctor's office is similar to the way that they go to the mechanic. Something's wrong. I don't know how much it's going to cost, and I hope it's better when I leave, right? And that's really how most, I think, both patients and even clinicians who go to other clinicians, we kind of don't know. There's a standard, but to only some degree. So getting closer to how do we have better diagnostics, right? And that's not just blood tests and imaging.
So basically what I'm hearing, going back to your Lyme disease example, is your computer kind of tapping you and be like, hey, buddy, you may want to check for Lyme disease here. You may have
exactly
that one. And then that
in
is
the same way in the same way, I don't know if anyone here uses Grammarly, or let's just call it spell check, right? Like it's just going through that information as a simplistic way of saying it.
Okay, that's actually, that's a great example, and definitely things are headed in that direction, but requires, multiple touch points, data inside the health system, outside the health system, that type of thing. Sunil, I'm going to put this question on you because it sounds like this is more, in your domain as well. So there was a question from the audience, and Dr. Lahr touched on it. Could you provide a pathway to go from obtaining the massive amounts of data from machine learning, the proof of concept, to implementation in a clinical setting?
So one thing I would start, and that's a great question, is build your descriptive analytics strong. So where you go and find out scenarios like, you want to build something for readmission, see how many cases you have for readmission and simulate that. Like if you predict well what value it will create. So it's basically like you need to analyze your data for a particular problem, how much volume of data you have. And if you do not have sufficient, do not move forward, because it's kind of, you go further and then you don't have enough cases, you cannot prove the value. But let me go and quickly touch on the Dr. Lahr's response earlier about the metrics and things. Here is the thing. 50 retail chains closed. Effect of Amazon. And what is Amazon was measuring their performance on? Customer obsession. They did not care about anything else. They were more focused on, can I improve customer experience so people can come there? Then they were having all other metrics about money and margin and everything, right? Mm-hmm. Healthcare is going to get disrupted by somebody with something like that, and everybody's going to start chasing them. That's what retailers did. They did not go online. They didn't read the things. They kept on trying to improve their store experience, which didn't convert into the better experience while Amazon was eating. Now everybody started following Amazon. Too late. That's what the reality check for healthcare is. We have to be open. Yeah. Okay, we got to open. So that's my last point. Thank you.
Well, we are a little bit over time, so I wanted to end here by thanking our panelists, you three, and thanking our attendees. I think this was a great discussion today. Hopefully we can continue these during our education series, and hope to the folks who are here in the Valley next week. Hope to see you at Desert Botanical Gardens in person if you can attend. And thank you so much for joining us today. So have a great rest of your Thursday.
Thank you. Bye-bye.
Thanks. Bye-bye.
Bye.